My voice is always louder than everyone else's, so I got to turn mine down a little bit.
All right. Okay.
I think I just bring it in quite close or something.
You're more comfortable with that.
Just hide the face in front of the mic.
Yeah.
So when did you go down to the CrossFit stuff?
So Avada, that's the CrossFit gym out behind us. They had the Avada Invitational, which is a big annual comp they've started doing. So we were supporting that and providing physio services, and we brought in chiros and we had some massage therapists there as well for the day. So so that was on the weekend just gone, and in between injuries and tweaks and so forth. And sneak a peek out the back at what was happening with the comp. So it's good. They get DJs out and they make it a big deal, and it's like a big
Full day, half day?
full day. Yeah. Long day. Yeah, long day.
Damn.
And I mean, it's you watch them, it's super impressive in terms of what they can do. But it's interesting in terms of the technique, because if you look at purist technique for lifting or exercise, it's quite different, because the goals of each workout are quite different, So you're watching people doing handstand push-ups, and how a gymnast might look at that is going to be very different to how a CrossFitter will look at that, And I suppose the physio that really likes, quality of movement and pure movement, there's a bit of a jarring effect there, because the two aren't the same. And that's not to criticize it. It's like, that's the sport. And what those athletes can do is nuts. It's super impressive. But there's always that part of my physio brain and just my personal brain that I'm like, oh, that could be done better.
Because I wonder if that is not dissimilar to, what would have been looking at the ballet and then akinning that to something like hip-hop breakdance or something, where someone was like, that's not dance, although impressive. That's not dance. So.
Yeah, totally. And everyone's got their angles and their barrel to push on this one. So I'm not choosing horse in the race. It's just I've got my biases to what I look for in movement,
Yeah. So you're not a CrossFit hater, Ben. What the hell?
Not at all, mate. Not at all.
CrossFit, I never sort of got into CrossFit, but I work with a bunch of clients that do, and they are all, at least the ones I've worked with, are absolutely jacked. So at least from that side of things, it does look like it performs very well from the aesthetic and the strength and whatever else side that goes on.
Definitely,
so far
mate.
as my small sample size of clients goes.
Greek gods and goddesses coming into that room, don't you worry.
Yeah. And so have you ever done, do you see the difference, much difference between the CrossFitters and like the High Rocks crew?
Well, good question. I feel like I haven't seen enough of the High Rocks crew coming through yet. I still feel like High Rocks is new enough that I'm yet to see the body archetype or the athlete that's coming through from that. So short answer is I don't know. But I think it's funny, like if you look at the CrossFit frame, like you can pick certain CrossFitters from how they look. And I think that the signifier for me is this thickness through the trunk. They're all real built, real solid through the trunk, almost to the point that the abdomen almost distends a bit, it pushes forwards. And I think when you watch CrossFit and you watch how they train, they spend so much time in loaded extension. So I think it's a part of that and part of just the sheer amount of force they're having to constantly load through the trunk. They just become hyper-developed through the torso.
That's a good point. I mean, you've worked with a few different sports, right? Like rugby, Western Force before they were...
rugby's where I've spent the most time working. Yeah,
I mean, you can pick a rugby body out.
They're not hard to pick. Lack of neck, again, thickness through the torso.
Yeah. Do you, like, now that when you sort of see people walking by, are you sort of, clocking those kinds of things just naturally day by day?
I think so.
Yeah.
I don't know if you can take that away, but that's part of being a physio as well, right? I think we're either trained to be highly observant, or we're drawn to physio because we're highly observant. Invariably you find yourself watching how people move, looking at like body shapes and archetypes and being like, wonder what you do.
That's why I see an airport now. So much fun.
Yeah, exactly. You're never bored.
Thank you very much for coming down. One of the main reasons that we want to get into today for our chat was talking about something that I'm probably not as familiar with, which is stress reactions and stress injuries, stress fractures, etc. And so definitely want to get into that. But I thought we'd just start off giving a little bit of history again, Ben, about, I guess, your journey into physio, what you've been doing so far. And so far as I could read from your bio, it appears to me that you've sort of been involved in, as you said, rugby through Western Force team. You've had some interesting clients or clientele with some of the travelling international acts that have been around as well. So maybe how did you get into this side of things? And then I'll finish up with, there's some advanced scope that I believe I saw as well. But maybe you can take it away from there.
Yeah, thanks, mate. So it's been a bit of a journey, and I suppose I've been doing it for 17 years now. It doesn't feel like that, and then you look back and you go, you've actually crammed a few things in there. So
Yeah.
it's been fun, but I guess the abbreviated version is so. Picked physio out of high school, not really knowing what I wanted to do. Knew I wanted to take a year off. Took the year off. Worked shitty jobs. Went traveling, backpacking around Europe. Nothing terribly original there. Then went to physio. Went through that whole process. Had a few crises through the degree, as I suppose some do. Got to second year, I was like, why am I doing this? And met up with a mate, and we went and hit up an architect, and we're like, talk us through architecture. So I nearly switched across to that, but went, no, I'll finish the degree.
He didn't sell you enough on the architecture. Didn't quite.
No, he
get
actually
you.
did the opposite.
Oh, right.
He was like,
Okay.
boys, the dream you think you're chasing is not what it is. And I still love architecture. That's still my little side thing anyway.
Okay.
Yeah,
Right.
yeah. But finished the degree, and by third and fourth year working with people, it was like, oh, I get this. I like this. Like this is good. Wanted to go into neuro probably, and then as luck had it, my girlfriend at the time, she got a job working for an Australian family over in France. Part of the deal was she got an apartment down the road to stay in. I wasn't going to pass that up, so we went across to France.
Yeah.
Went there for a year. Even though I was about to start practicing, I was like, well, you're not going to pass that
A
up.
year in France. Yeah.
100%.
Free rent. Yeah. Fair.
Exactly. So I washed boats instead, and that was lovely. And then as I was coming back, a mate of mine who I'd graduated with, he was working for Ascend Physio over in Mount Claremont, so fantastic clinic there. But it just wasn't, the profession wasn't for him. So he was leaving that, and he said, oh, Ben, there's going to be this job going. You interested? And so I put my name down there, and Pete, my future boss from Ascend, just happened to be best mates with my reference on from my CV from my rural prac days. So it's just this
Done and
great
dusted.
coincidence. So
Yeah.
good personal, coincidence there. I got a good reference from Derek down in Esperance. Thanks, Derek. And then started working at Ascend. And so from there, like great sports private practice, they were covering rugby amongst other things at the time. So looked after all the state junior teams, Western Force Academy. So I started doing that, building up through that pathway.
Did you have any association with rugby prior to that as well?
No, I grew up here. I was a footy player, if anything. So for me, this was very foreign.
AFL.
Yeah, exactly. And so the mind takes a bit of adjustment. I was going away on these state trips with and spending like hours on hours listening to coaches talk about rugby. I was like, far out, when does this get easier? But then gradually I was like, oh, now I can see the strategy, and now I can understand the game. And as that started to tick over, it's like, oh, cool, now I'm interested in this.
Yeah.
So then I pulled the boots on and started playing rugby, because I thought if I was going to be a decent rugby physio, I had to actually play the game as well. So it was funny because, this Irish physio mate put the heat on me. He was like, Ben, you've got to put some weight on. You're going to get killed out there. And so I ate lots of nuts and protein and trained in the gym and put on maybe 3 kilos onto my whippet frame.
Solid.
Yeah, exactly. So played some rugby, and then, just gradually kept working through rugby, which was great. Like I loved it, and good community of people. As a sport for physios, you see everything. So most sports, you end up seeing just like a microcosm. If you treat swimmers, you're seeing a lot of shoulders. But when you treat rugby players, you see everything. So as a breeding ground for a physio, it's great because you're getting exposed to all sorts of stuff, which is really cool.
Were there any particular injuries that though were a bit more common from the rugby side? Like I would have thought some collarbone type injuries or.
I'd probably put shoulder right up there.
Mm.
And to this day, shoulders are probably my favourite area to treat. Get loads of instabilities, labral tears, dislocations, lots of post-surgical stuff for guys that need different stabilisations, lots of AC joints, the odd fracture here and there.
How do you pop an anterior dislocation back in?
Well, I'm actually better qualified to speak on this now doing the advanced scope role than I was back then. Back then I had a couple little...
Back then it was just a little punch in the arm and back in.
Not quite. I tried to avoid that. It was a bit of whatever would work on the field at the time. But these days it's funny because if you get to them on a rugby field within the first 20 seconds, they haven't got muscle spasm kicking in and so forth. And typically it's not too hard to relocate them. Sometimes you can just get them kneeling, bending forwards, and you can use a little bit of traction rotation to get them back in. If they've been out for minutes on end and minutes becomes hours, by the time they get to the ED, there's a whole lot of muscle spasm and other things going on. There's a reason they haven't gone back in easily, right? But then again, there's a whole bunch of well laid out techniques that you can use for this. I've got my preference for what it's worth. It's called the Cockers technique, Kocher,
Okay.
and it's a sitting based. It starts as a sitting based technique. When actually I'd reference Neil Cunningham, who's a guy from over east who's developed a lot of really fantastic techniques for getting shoulders back in. And he's got a technique which is basically, you've got the person who's dislocated with a hand resting on your shoulder, and you're sitting there gently massaging trapezius, bicep, deltoid, trying just to reduce muscle tone. And that, for a percentage of people, will actually get a shoulder back in. I've never been lucky enough with that. I'll always start with that to basically get someone to relax, let go. Because if someone's fighting you, it doesn't matter.
Okay.
And that's the reason sometimes you have to sedate these people, is because they can't let go. The whole purpose is you need to get the person to let go.
Right.
But then, Cocker's technique is basically you're getting them to relax. You're rotating the arm out here as wide as it will go. And then from there, you passively flex the arm up this way. And it can be quite uncomfortable. You've got to sort of get a read on your position. Once you get them to about 90, you'll feel it's on the edge. And you can usually feel it reduce in that movement. And then you'll bring them up over here, put them back down.
Okay.
And so that's my preferred technique. It's worked for most of them, but not all. There's some you can't get, and they need to get sedated.
Damn. How many times do you try before you go, all right, time to...
Well, yeah, you might spend 5 to 10 minutes trying, and these aren't forceful techniques. Like, you're not sitting there yanking on shoulders. Yeah. I've seen that, and it's not a good look. It's like, I wouldn't want it done to my shoulder, and you can cause, cartilage damage and all those sort of things. So you want them to be relatively non-forceful. So I'll spend 5 to 10 minutes working with these techniques, and if we can't get it, and I've tried multiple techniques, then we speak with the registrars, we speak with the consultants, and we usually go next steps to sedations.
Yeah. Are there techniques that were common that maybe aren't so common now, or maybe outdated, that you're aware of?
The whack them on the shoulder and put it back in.
Yeah, okay.
Probably.
All right, so definitely no punching it back in.
Yeah. I don't know them by name, but yeah, it's probably evolved to, I think, these more gentle techniques, less forceful.
So you were going through into the rugby side of things, and then eventually started up your own private practice, in large part because the Western Force and Super Rugby had to part ways?
Yeah, so that was the catalyst. So yeah, I spent sort of 7 or 8 years working private practice and part-time rugby, with then sort of increasing rugby over those years. And then it got to a point where I had to make a call to either buy into the clinic and continue with that, or go full-time force. And I chose to go full-time force because I felt like I hadn't fully immersed myself in that zone yet. Mm-hmm. So I spent a few years doing that. And then that came to a point where, the Western Force, and there's a whole, you can read up on the history on this one, but unfortunately lost their license in Super Rugby. And so, I went from May of 2017 being like, oh yeah, we may not be around in a few months, but still thinking, no, we're pretty good. We've got a good legal case. We're getting lots of bums on seats. The game's growing here. There was a lot going for rugby in WA at that time. So it seemed really weird that we would go. But at the end, it was a political and legal decision more than anything. The Force had to be the ones to go. And then by August, it was like, oh, geez, this is getting close. And then I started looking around as to what I was going to do next. When we found out, I was weighing up a few options at that time. I was like, do I move down to Denmark and just set up something in the country? Do I try and go over to Melbourne and chase something with an AFL team? Do I go back to my old clinic? What do I do? I had a not yet 1-year-old kid at the time. There was a lot going on at home. But because I had no responsibility over what happened to the Force and how that happened, I just couldn't handle the idea of not being responsible for my job. So ultimately I went, okay, if I start my own clinic, then it's on me. If it goes well, it's on me. If it doesn't go well, it's on me, but I can live with that. So then I was like, that was when I made the call to start my own clinic. So yeah, we all got made redundant, unfortunately. The Force did resurrect, which is great to see. But by that stage, I'd moved on and into private practice land, and that's where I've been for the last 8 years now. And it's the same time frame I've been doing the advanced scope job in ED, because I wanted to seek out something that would give me that acute fix. I mean, I'm still a sports physio by background, and so I like the real acute pointy end of what we get in the emergency department.
I'm interested to know from the rugby side. So how long were you in the Western Force for, roughly?
It was 6 years with the pro team, some of that part-time, some of it full-time.
From beginning to end of that journey, what was the main development from your physio side of things, do you believe? Was it the ability to assess and treat shoulders, or was it some other change that you noticed? Oh, wow, me from at the beginning of this journey compared to me at the end, this was probably the largest change.
It's a really good question. I think it's accountability. So when you work in private practice and you're working with patients, clients, whatever you call them, ultimately, most of the time it's just they're responsible to you and you're responsible to you. But when you're working in that environment, you're responsible to the player, the strength coach, the head of athletic performance, the doctor, and then all the coaches, all the management and everything behind that. And any one of those people can pull you up at any moment and go, Ben, why are you doing that? Or explain to me what you're doing here. So you've got to be very clear on exactly what are the decisions you're making and why with each of these players. So what it gets you to do is just constantly think through your why. It's like, why have I given this person this exercise? Why have I chosen to do this? I was running the rehab program for a few years there. And so every decision you make, like I've written out a bloke's whole week, like morning, afternoon, everything they're doing. So anyone can call me out, and like players included, coaches, and be like, Benny, what's this about? And if you don't have a good answer for that, like mud on your face, right?
Yeah.
It doesn't look good. So I think you get really thought through on, okay, I'm doing this program and here's the reason. Everything's got a reason behind it. And that's a large part of what I chat about with my team at the clinic. So these days, in terms of trying to improve them, if they're telling me what they're doing, I just keep saying, why? Why? They probably get tired of me saying why. But it comes from a good place because it's like, if you know your why, if you know why you're doing something, you're thinking it through, and that becomes more automatic over a period of time,
I mean, yeah, that's especially true for when you're first coming into the profession, or you've done what you do as uni students, which is a bit of rope learning, the sort of taking information. This is the marking criteria. Follow what the marking criteria says, aka just say and do the things which is telling me to get the marks.
Yep. Jump
More
the
than
hoop.
anything else. Great, that'll do. And therefore, you sort of build in these little patterns of like, all right, I just do this, and you forget to ask the question why. So, I think that's a very valid point and a really good piece of advice for even old physios as well. Even someone that's been doing it for a while, you can get caught into your own patterns a fair bit. So
Yeah, and that question helps shake you out of it, right? So if you really critique what you're doing and you constantly critique, I think it means you're always growing as a physio, as a person, whatever. But I think it helps me to feel like I continue to evolve if I can keep questioning what I'm doing.
yeah, which I think there's another good point on that, which is giving yourself a little bit of additional time. So not necessarily working with clients back to back from 7 till 7 sort of thing, where there's no time for reflection or there's no time for sort of updating, because at that point you can only be working through some version of pattern recognition. But yeah, giving that little bit of reflection, whether it be end of the week, end of day, I think that makes a big impact as well. Or if you've got a couple of minutes at the end, I mean, the notes is a good chance to do a little bit of that as well. So we go from Western Force into private practice. You start building up the private practice. One of the big things I'd like to know from your point of view, and maybe it's hard to distinguish because you were sort of wrapped up into sport during your early private practice years, but what do you see is the difference between, professional sports physio type work versus general population private practice type physio?
Yeah, I think there's a couple of things. Probably the little mantra I keep coming back to in private practice is you're trying to find what's the 20% of things that are going to make 80% of the difference. So in that, for example, in that rehab role at the Force, I can write down 100 exercises for someone if I think it's a good idea, and all these other strategies, and put them into the week, and they'll do them because it's in their benefit. They're after the 1%ers. In private practice, you can't do that to people. You've got a 40-year-old mum coming in doing an ACL rehab for you. I can't write her the same program. She's got, a part-time job and she's working on things at home. She's looking after kids. It's like, it's too much demand. So I've got to write a real concise program that as a sports physio purist, you might look at it and go, there's not enough in here. But it's like it challenges you to go, okay, well, what is the most bang for your buck you can get out of a program for someone that has life challenges and time constraints and all these sorts of other things. So I think it's that really being specific on like what are the few things you're picking that are going to make the biggest difference. And if someone does want to go the extra mile and want to put in the extra work, then great, you just keep chasing that in. But I think a lot of time in private practice, you don't get that. So I think that's one of the elements.
Yeah, because when you're now seeing people in private practice, are you seeing more? Is that quite a mixed bag of sort of athlete, non-athlete,
Yeah.
semi-pro, a little bit of pro? Like for right now for Stack Physio,
Mm.
and you guys are based whereabouts?
We're near Fremantle,
Okay.
O'Connor.
Do you find that again you still deal with a lot on the rugby side, or now again it's just a very widespread sort of demographic?
Yeah, it's fairly widespread. It's a bit of everybody. Like when I started it, coming from that sports zone, I looked at it as really setting it up as a sports specific clinic. South of the river, there just wasn't as much there. You know, a lot of the main sports clinics tend to be north of the river. So there was in that area, I thought, look, we can really look after this. But it's funny, and maybe it's bringing on, other team members over time that your identity changes a bit. And as you drift a bit away from that sports thing, it is very much you're seeing the whole population, but we see a very active population. So everyone that's coming in, they can see our gym, they know that they're going to get exercises, all that sort of thing. So we're still seeing people who want to be active and are really good at, putting in the work. But it's not like I'm seeing pro athletes back to back these days. So,
Sure.
yeah. And probably my identity as a physio shifts a bit along with that.
Yeah, what's that like?
Um, I miss parts of the sports physio, like the pro sports thing, because you really can practice at a real pointy end, and I like being challenged. So I like working around people that'll question me and challenge me, and I keep pushing my team to challenge me more. So this is still an open invite, guys. You can
Yeah.
have a go at me.
How grill him?
Yeah. Um, so there's another point I wanted to make on that. No, the brain's flying
That's
away
all
on
right.
that one at the moment.
With the type of work that you do, both within the sports team and again now in the private practice, I think one of the important parts to sort of highlight to oneself as well is some of the mistakes that we make along the way. And are there any mistakes for you that sort of stick out as real big sort of learning moments that gave you a little bit of insight into yes, maybe I didn't ask enough of a why, or I feel like now that's changed how I would look at a certain treatment cycle or an exercise protocol. Are there any sort of mistakes that sort of stand out to you across your journey so far?
Yeah, good question. Um, are you meaning anywhere along the journey?
Yeah, yeah.
Hmm. The pause suggests there's no one thing that stands out, which also might suggest I'm not being critical enough of myself, or I've blanked on the error, because I've certainly made them.
Because I would imagine even in the early days of being at the Western Force, the ways that you would have provided even the exercise rehab protocols from the beginning towards the end, like every single time, we should always be looking back, thinking to ourselves, "Wow, that was not. I could have been doing so much better."
Yeah.
Because if you're not doing that, then you simply just haven't changed over that period. Like we
Yep.
should always be looking back at our previous work as somewhat embarrassing, or oh
Yeah.
God, how naive, or how ignorant.
Yeah.
Um,
That is true, and it's funny because sometimes I've still got on file a bunch of the programs that I've written back, when I was working in rugby, and sometimes I look at them and go, why was I doing so much of that? I remember we went through a phase where we were doing loads of isometric loading for different reasons, and I mean the jury's out on that one. But I look at some of the programs and I go, that took forever. That's a lot of isometric loading, and I certainly don't write that much isometric exercise into people's programs today. So there's things like that. But if I think about more some of maybe the poorer outcomes or like things where it could have gone better, it's probably around communication. Like in the rugby sense, it was like any of the biggest issues that we had was probably because not all parties were on the same page. I'm doing something, but I didn't tell the strength coach that that was what was going to happen. Or I can remember one event screening players in the morning, and I'd screened. We had a process for screening all the players. It was a bit frantic that morning. my head physio at the time was up in meetings, so he wasn't down, so we were stretched. I'd ID'd that one of the guys had like some mild hamstring tightness and some neural tightness that morning. Me and my boss we hadn't spoken on the way down because it had just been frantic. So we got to the field session, and this player had a mild hamstring strain, nothing terrible, but he had a hamstring strain during the session. And I remember my boss came down to me like a ton of bricks for that one. So I've never been blasted so much in all my life for that. And I could go into details on that one a bit more. Why I don't think the way that got handled was actually ideal either, and it's shaped some of my current thinking around managers. But it was an interesting one where you kind of go, okay, well, I dropped the ball in communicating something that ended up being meaningful and impactful to training.
You could say more on the managerial insights.
Yeah. Well, what was interesting there was like when I got lambasted for it, there were a couple of comments that were very personal and like really affected me. I had to go home that night and I was in a dark spot and I was really beating up on myself and so forth. And so it took me a while to process through that. But as I did it, I was sort of reflecting on the language used, and I thought, so I got called a management challenge that needs to be brought up to scratch. There you go. I can still remember that 10 years on or so, 15 years on, whatever it is.
Giving you chills, as you say it.
Yeah. No, I've moved past it. I'm okay. I've done my healing. But yeah, I was like, wow. I didn't think I was. That wasn't like the identity that I saw myself having there. I was like, I've been pretty diligent here, and it's been a pretty challenging preseason. And at that stage, that the head physio had come in late to the season. We just really hadn't had a lot of time to gel our processes as a team. And I thought, this jars with how I feel about all of this. So it took a bit of processing, and I didn't sort of go back at him for that or anything. I just thought, okay, I can reconcile this in different ways. I don't think that that's how I perform in this team, but I'm going to prove that I can work it exactly the way he wants me to work. So I made sure for the next few months, every single little detail, anything that happened, I talked to him, I'd send him a message, whatever it was. So he knew that every single thing I was going to do, I was completely across. So it was interesting. And I've had a few bosses there and a few physios at different stages. And, one of the next bosses I had was very different in his management style and much more of I'd call him a master delegator. And this is a compliment. So hello to Midzi. But one of his great skills was going, no, Ben, you just do this. I want you to do it. I trust you. Go do it. Get it done. And then tell me how it goes. Whereas previous boss had been a bit more of a micromanager at times and just wanted to like have a bit of a hand in every pie. And I certainly preferred that style of delegation. If your boss trusts you, they say, yep, you've got this. You just go do it and then report back to me. I think that's much better. And I think delegation is actually a key skill. So it's something that I try to do at the clinic is like, hey, this is your thing. I trust you with this. You go get it done. And then we'll chat about it afterwards.
You don't have any little micromanager tendencies?
Ask my team.
Yeah, true.
I try not to.
Give us the goss team.
Yeah, exactly. Yeah, we'll give them the mic.
So one of the main things, again, that we wanted to talk on a bit today was the stress injuries, stress reactions, stress fractures, etc. And maybe even just to begin with, you might want to give a little bit of an overview of what even is a stress reaction or a stress fracture and how we might want to start thinking about these things.
Yeah. Well, look, I'm not the walking definition here necessarily, but so a stress injury is it's a continuum of bone injury, a spectrum of bone injury that's caused by progressive strain on a bone that eventually will exceed its capacity. And so as a result, they're typically injuries that occur progressively and gradually over time. By the time you identify them, they're already in process. So there's been some background to get them to that point. And there's grades of them. So the grading process, understanding a person's biology, understanding their risk factors, understanding what they do, whether they're training their sport, is all really critical to diagnosing how severe they are. And then how severe they are combined with the location of the injury usually will determine how you're going to manage them.
So who are the kinds of people that you typically see having these types of issues?
For me, and I think for us at the clinic, it's athletes, but it's also just recreational sports people. There's a whole nother subset of stress injuries, which is your kind of insufficiency fractures or your pathological fractures. So this is more your older cohort, or bone compromised cohort. So I think that's a distinction. And for the sake of what we're talking about, I'm not really talking about that cohort. It's a different beast. I'm talking about the cohort that has generally healthy bone, but for various reasons will get stresses that exceed that bone's capacity at a point in time. So for us, it's athletes, and classically it's the athlete who's had a training change. So it's the person who's picked up high rocks, having not done any running training for a significant period of time. Or it's the person who's started joining a run club and getting into that. So it's unaccustomed loads typically, but it can be a lot more nuanced than that. And that's why I think stress injuries are really interesting, is because they present in all different ways and forms.
We mentioned sort of off air as well that you had an interest within sort of systemic type interactions and autoimmune disease, and I guess how that can also play a part. Is that sort of what you're talking about in part when you're saying other sort of contributing factors that might be relating to these stress injuries?
Yeah, it is. And in a way, this isn't a literature term, but I sort of think of them as you've got simple stress for injuries or stress fractures and not simple stress injuries. And for me, pardon me, the simple ones are the ones that are quite biomechanic or load related in nature. So if someone's made an obvious training error, they haven't been a runner and they've just simply built up running too rapidly and they're starting to get a hot spot on their shin, that's pretty straightforward. It's a training error, more than anything. You can look at the biomechanics and you can look at individual factors, but ultimately they've made a load training error. So that's relatively straightforward. But where you've got people who've had no significant changes often to training loads, or they might not do a lot of impact loading at all, and they end up developing a stress injury, then you've got to dig deeper. These are your not simple ones. And that's where you've got to start asking the question, okay, what's going on with this person's bone health? What's going on with maybe some systemic inflammatory drivers? What's going on with other things in their life? Like, what's the context here that might lead them to be at risk of a stress injury? And that's not a simple process to figure out.
Are there types of questions that you typically ask people in order to try and draw out some of that information that makes you go, that's an important feature?
Yeah, absolutely. And it's probably almost like a checklist. And I'll usually preface it by saying, okay, you've sort of examined them or even just spoken to them and said, I'm just wondering about a stress injury as a possibility here. I need to ask a bunch of things about this because there's a bunch of variables that we know could be related. So I'm going to have to talk about their sleep and ask them about sleep quality because we know that's a factor. I'm going to have to talk about their diet. I'm not a nutritionist, not a dietitian, but I have to understand some fundamentals around macro energy intake and outtake. Are they simply eating enough food, enough protein in particular? And then what types of foods are they eating? We need to know about calcium, vitamin D. So it's like, does that person consume dairy or do they not? Do they eat meat or do they not? Because I've certainly seen a higher incidence of these injuries in people who are vegetarian and in some cases people who are vegan. And again, that's not a criticism. It's just simply to say, well, maybe there's some blind spots in the diet there that might be contributing to some nutritional reasons behind these. And there's literature on this.
So if that is the case, if someone is perhaps missing an adequate amount of protein, or whether it be vitamin D, calcium, is that simply just a supplement more or eat more?
Well, I'm probably not qualified to go right down that line.
We'll
There's
put all
guidelines.
the caveats in place. Not a nutritionist, but best guess.
Oh, and I'll still happy to tell you what I do on the ground. But that's because this is the thing I'm saying to patients is like, hey, I'm probably not the guy to go right down the mine with on what's your diet, and you probably need to think about seeing your GP to look at bloods and looking at ferritin levels and looking at vitamin D levels and all these sort of things. And you may need to speak with the dietitian about what does your overall diet look like here. But there's some simple rules of thumb. There's guidelines on 2,000 milligrams of calcium a day once a bone stress injury is identified, 800 IUs of vitamin D a day, which is actually really low. So normally I suggest going over that. 800 IUs.
That's very, very
units.
low.
Yeah. So that's the thing. Normally I'm saying, well, you may as well go north of that. But again,
I think it's 4,000 IUs was
Yeah, we used to give 5,000 IUs to the force players every single day, whether they had a
Yeah.
bone stress injury or not. So I don't really see the harm in giving people higher doses of vitamin D. But that's just, again, just research numbers. But certainly you think, well, in most people, vitamin D is going to be safe. Calcium hopefully is going to be safe. Again, they've got to speak about it with their GP if needs be. Protein intake is going to have to be at 1.5 to 2 grams per kilo body weight per day. There's no evidence that I can see that collagen supplementation specifically helps stress injuries, and I've looked for this. But look, maybe as part of a broader, protein intake approach, that there might be scope for that. And total calories as well. If there's any flags that suggest that these people are just not eating enough, and sometimes you'll see this in like the younger female athletic population because they are outputting a lot of energy. This is the Red S thing, which you'd be familiar with, and there's lots of other good resources around Red S, relative energy deficiency in sport, for those wanting to break down the acronym. But there's a few of these touch points that I think that we can in that first consult be like, okay, let's bring these things up to scratch. As a very base, let's bring all of these things up to scratch. So we'll talk about those things.
Is that something that you're going, okay, like we want to try and lift these up? Maybe it's worthwhile getting a blood test so that you can properly measure these things. And then is there, again, things to avoid that you're sort of commenting on? Like, is the average, processed foods and soft drinks, is that something that seems to be associated that you're aware of, or not so sure?
Short answer is I don't know. I mean, intuitively, it would seem to be the cleaner, the more whole foods your diet is, the better it's going to be in that regard. Alcohol I will touch on if I think it's a thing, because we know that alcohol is just detrimental to tissue healing, full stop. Doesn't matter what injury we're talking about. But I don't tend to go too deep on the specifics of the diet. I'm sure there's benefits to it, but it doesn't tend to be my angle. And again, it's probably the 80-20 thing coming out in another way.
Yeah.
I'm sort of choosing my battles.
Yeah.
Because if I give people too many instructions, it may not go so well.
Yeah. Hydration? Have you seen, does that play much of a key role?
I've not seen it pop up in many of the papers that I've hunted down. You'd think intuitively it does, and possibly even like electrolyte balance to go with that. But I don't know specifics on it.
So if someone comes in with a potential stress injury, so you're giving a rough, all right, we want to improve some basic markers to make sure that the system is as good as it can be to try and, one, prevent further degeneration or inflammation of this issue. And if we can then start the healing process, what's the next sort of move for someone?
Well, then obviously the thing we're talking about is bone loading. So I don't know if that's the rabbit hole you want me to go down on that one, or are you meaning more in terms of other lifestyle and other health things at that point?
Bone loading is probably where I was heading towards.
Yeah. So, I mean, the bone loading thing starts with diagnosis, and that's where I think we've got to get really specific on exactly, first of all, which bone is it, because there's high risk and low risk stress injuries or stress fracture sites. So you've got to know what you're dealing with. If you're dealing with a distal medial tibia reaction, look, you can be a little bit more aggressive with how you manage those ones. If you're dealing with a proximal anterior cortex tibia, you've got to know that that's a high-risk location. And if you progress that one or you don't get aggressive with your offload for that, that can go really badly. So you've got to know the location, and you've got to know your high-risk and low-risk stressors as a starting point. And then you do need to image these. I will generally refer to a sports physician for these. Partly to assist with the imaging, partly as another opinion on it, and partly because these people will typically need bloods-based workups. So they need someone more qualified than me that's going to talk about the hormonal influence and what their blood panels mean and all these sorts of things. So I always want to tie them in with the doctor and the sports physicians. I've got a bunch of good sports physicians I value working with. So I'll always refer any of these off to a sports physician. And then typically then we're getting the imaging done. Usually it's going to be MRI because that's gold standard for grading these injuries. And then that will give, once we've got our location, our grade, that gives us a bit of a blueprint for how we're going to load it. And in simple terms, it's how long are they doing nothing on it? How long are they reloading it to just body weight, walking, body weight exercise? When can they start reloading it? and this is, resistance-based training, then when do they start impact? And that's particularly for your lower limb stresses, which is most of what we're talking about. They're kind of your key time frames as to how you go. And then each location and risk type varies as to what that looks like.
Yeah, do you see much in the way of stress injuries above the waist?
Personally, no. You can see them in people who do produce high velocities, so baseball pitchers, water polo players, things like that. But they're uncommon.
Yeah, sure. So then when someone is, going through this process now of sort of deloading and trying to figure out what this timeline is going to be, obviously it's going to be quite varied based on, as you say, location, grade, etc. Is there the simplest form of stress injury, is there a fairly, is there somewhat of a quick turnaround? We're talking in the space of weeks, and then in the long form or sort of the more complex, potentially poor location, higher grade type injuries, are we talking months and months and months or years? What's sort of a rough gauge between the shortest and the longest? I'm guessing it's quite a big one.
Yeah, you're right. At the shortest end, again, I'd come back to your distal medial tibial shaft stress injury. Someone that's got a low grade one of them, you may not even pull them off running. You might just modify. You might modify volume down. You might space for higher recovery time between sessions. You might change a couple of training parameters, but you might actually be able to keep them running and loading through it. Because this is the injury that for years got called shin splints, right? And people still use that term. They talk about it. Shin splints doesn't tell us very much. That doesn't mean a whole lot. But really what's happening is that we've got a bunch of people out there that are training through low-grade stress injuries. They're calling it shin splints, but really they're training through low-grade stress injuries. And a lot of them will resolve. Again, it's a low-risk location. If they don't cook it too badly, then they gradually get better. But it's one of the reasons they take ages, because arguably they're dealing with a stress injury and they just go, oh, it's just shin splints, and they keep running through it. So they continually piss it off. But that's one that does have better capacity to heal. Through to, I've seen, a gymnast take 20 to 24 months to get back after bilateral navicular stress injuries. So,
Oof.
Yeah, brutal. So
in the foot, for anyone that's not sure what the navicular is.
Yeah, exactly. So that's a pretty brutal one. And that was an interesting case, actually, because the advice that she was getting from the orthopedic, so she didn't have surgery for these, but was under the care of an orthopedic surgeon, which, again, for a high-risk stress injury, that makes sense. But his approach was quite conservative, as is often the case with a navicular. But, she's getting serial MRIs, and it's showing that there's still not a closure of that dorsal crack in the navicular. But then when you get 9 months, 12 months into essentially a rest-based protocol, and it's still not healing, this is where I couldn't agree with the offload any longer. Because, bones are living tissue. We know that it's stimulated by load. And often we have to stimulate that bone to get it to adapt. And so this, to me, is the interesting tension in stress injury management at the moment, is that the old school was, just rest it till it heals and then gradually build it up. And in general, that's okay. But there's much more contemporary research showing, well, if you offload it for too long, then you get further bone resorption. You're failing to stimulate the bone to heal. Because if you don't load a bone, it just goes, okay, that's fine. Mm-hmm. I'll continue to deload my bone structure and I'll continue to get weaker. And of course, what does that do? It exposes it as you start to reload it again. So the balance here is in when do you actually start to load these bones again and start to deliberately nudge them as a means of osteogenesis, as growing bone, putting down new bone.
Are there any methods that are being used? Like we don't have that much across Australia, but we've got things like injectables as an example, PRP. I don't know if there's any research behind using anything like that for something like a stress injury. Are there any other outside modalities outside of other, rest or reload and nutrition that you're aware of that may help move the needle? Are people sort of trying to sauna or ice bath, or are people trying to get into an oxygen hyperbaric chamber, or are there any other sort of things that athletes might be using in order to try and, battle these things?
I imagine that the athletic crew are trying all of that stuff, and I'd be interested to see some sort of case series on some of those approaches. There's a couple of fringe injectables, so it's not typically amenable to like a PRP. Cortisone would send these backwards. It'd be a terrible idea. hyaluronic acid. I mean, you're not really going to inject that into the bone itself. But there's some fringe injectables which are kind of getting explored but haven't really hit enough convincing literature to be like, oh yeah, we can use these now. There's shockwave therapy's been looked at for it, but the results don't look super convincing. So there's not enough for me to recommend that for people at the moment. Lipus, so low intensity pulsed ultrasound, that's not new. That's been happening for a while, but there is evidence for it in terms of bone healing. I've used it for certain athletes here and there. One of the challenges is sourcing the Lipus machine itself. We don't have one at the clinic. And typically people got to take it home. They've got to be using that daily as a bone stimulation thing. It's hard to tell. One of my recent stress injury girls, she took one home, but she had a bunch of other things going on as well. So did that make a difference or did it not? Hard to say.
Sometimes it is just nice as well, though, for someone to have something that they've got to sort of work on as well.
But I think big rocks, like unless you're covering these big rocks, and sleep's a massive big rock that we haven't really touched on. But these are things that are going to be highly restorative to healing bone, the dietary side, the sleep side, where your system is at overall. There's papers that have come out in recent years that have clearly linked stress to sleep. So again, just anything that's physiologically loading the system is going to be an input to bone in particular.
So how often are you seeing in clinic, if you've got someone that's coming in with a stress injury, that you are seeing that these other domains are being affected, sleep, nutrition, etc.? Is this 90% of the time that you're seeing that there's overlap between sort of potential system failures or at least things that could be improved upon? Or are there sometimes athletes where, again, you're just going, you're doing everything right, it was just an unfortunate load incident?
Yeah, I think more often than not, what I'm seeing is these other variables come into it. And it might not be terrible, but they're there in most cases that I'm seeing. I think at the pointy end athletic population, you might be more readily able to identify things as a biomechanic error or as a training error. And if you can adjust for those, okay, on they go. And typically athletes are putting themselves in a pretty good situation to recover. Not always. And you and I both know a case at the moment that we're kind of collaborating on that's been a real challenge to get right. And I think there's a lot of variables there. One of which is sleep. There's a range of variables, but this athlete has poor sleep, and that relates to a whole separate thing that she's had happen. It dates back to a different injury, but that is now hanging over and providing a spectre over healing and recovery for a current injury. So it's not as simple as me turning around and being like, oh, you got to sleep better or you got to improve your sleep habits, because that's not a straightforward thing for her. She's trying, but it's not straightforward, but it is having an influence on her body's tissues recovery.
Yeah, it is one of those things as well where people, athletes, non-athletes, will be aware of some of the issues that they're having as well, and sometimes the reinforcement of you're not doing this good enough, there is the potential for that to be sort of a sort of a way that someone can start to feel even worse about the situation as well. It is a really funny, and I'm sure you feel it as well. It's always an interesting conversation that you're having with someone, trying to work out how do you try and get the person to recognize what it is they need to do, which they probably already deep down know that they need to do and improve, without crushing spirit, but trying to get it into sort of self-motivation. And then even if you get it to that point, plenty of people are attempting to fix things which simply are not straightforward. It's not as simple for some people. Just go to bed at the same time, wake up at the same time. Someone might say, that's all well and good, I'll get into bed at this time. I don't sleep until 3 hours later, or I get fractured bits and pieces, or I've got restless leg, they can't stop moving, or I've got X, Y, and Z other issue going on, and there is always that little delicacy of how do you sort of try and push in the right direction without pushing off a cliff.
Totally, and I think with the way physio's moved in the last 20 years to this much more biopsychosocial approach, and we're talking much more about identifying all these variables and factors that can be involved in pain or involved in healing. While we've gotten better at identifying them, we don't necessarily have the tools to manage them. And so, like you say, it's all well and good to figure out, oh, sleep's an issue. But if like you're saying, all you do is bring that to their attention, and now they're like, oh shit, here we go. Now my physio thinks my sleep shit as well.
Mhm.
Without providing some sort of handle to how can we actually assist this, like a meaningful path to like, okay, we've ID'd it. What's the plan to actually help that out? And look, I personally am a believer in staying in my lane. Like if I don't think I'm qualified to manage something, then I'm going to say so. But then I'm very careful to be like, I might ID something in a consult and be like, oh, this is a problem for this person. But it doesn't mean I'm going to bring it up. And it's because I don't want to give that person, like you said, something else to stress about or worry about. If I think I can provide something meaningful to be like, I've got a strategy for this, or I think we can help you through this, that's useful because then you can be, hey, I think this is related. Can we try this? So I think if you've got that tool in the shed to be able to help them, that's great. Or you know someone who you can put them in touch with. But I think we've got to be really careful around just IDing all the problems in someone's life and
Mm.
just spitting them out, being like, oh, look at all these factors related to your problem. We should be identifying them, but we've got to be real careful around how we communicate that to people.
Yeah, this is where I think through university it was health promotion was aimed at us as being a big part of how we should be sort of a first responder in a way where we're kind of like the first line of defense in a lot of people's healthcare. And so because we also get additional time compared to maybe like a GP might be able to manage across the day as well. And so the idea was that if someone's coming in that appears to be unhealthy or having unhealthy traits, that's a good opportunity for like education and da 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 da. And one, not only is that in some instances like an uncomfortable thing, but I also don't see it as very valuable because at least in some cases, because someone might come in and if someone's a bit overweight, before I say anything, they most of the time someone will say, "Oh, yes, I know, I need to lose some weight," and I don't need to then jump down the throat and be like, "Yeah, that's absolutely. If you lose some
Yeah.
weight, that'll solve all your problems," because that's not necessarily true either. Of course, getting healthier, absolutely support exercise, celebrate the wins of, all right, we're getting up for a walk in the morning. Hell yeah, let's like
Yeah.
5 minute walk, sweet, go for it. But simply just jumping on all the negative associations the person already has with themselves and then blaming all those things as like, well, that's probably the reason why X, Y, and Z, when you don't know that to be the case,
Yeah,
right? Someone that comes in
totally.
and has got some knee or hip pain or something and they're carrying a bit of extra weight and they go, there's a bit of extra weight. You could so easily say, that's probably the reason why this is the issue.
Yeah,
And
and it's
you have
almost
no
a
idea
cop
if it's
out, right?
it is a cop out. It's a massive cop out.
Yeah, yeah. And I think going back to the example of the young mother, she doesn't need me to tell her that her sleep sucks. She's getting woken up by two kids at multiple like intervals in the night. So me banging on about sleep quality being related to her bone stress injury not coming good, it's not really helpful. I've got to find another angle there.
Are there some stories of stress injuries or even a story of a stress injury that you found particularly satisfying it sort of went exactly to plan and the person sort of came out the other side and you're like, all right, the system works.
There are, and most of them are what I call the simple stress injuries. They're the ones that are like, okay, you don't seem to have many of the risk factors or variables. We've screened for all these other weird possibilities. We can't find any of that. There's a clear training error. We're going to do this plan and this protocol. And they just sail through it beautifully, and you go, yes, win. Okay, back to training, on to the next. If I think about the not simple ones, so I think about the ones where there's been overall health issues or metabolic issues, dietary issues, sleep issues. They get there, they just take longer. They don't follow the typical pathways or pain behaviours you'd expect. Because what you're looking for with the stress injuries, you have these tests that you do in the clinic that you reproduce, and you're going, oh, that was a 7 out of 10 pain on that single leg hop. Oh, 2 weeks later, that's a 4 out of 10. 2 weeks later, it's a 1 out of 10. Great. We know we're moving in the right direction, What I see with the ones that have got the variable inputs, like the more physiologic inputs, I don't think they follow those paths in the same way. And it might actually come down partly to pain biology as well. Because again, if you've got, say, some systemic inflammatory influences, who's to say that's not influencing what someone's feeling at a certain location as well? So I think it gets harder.
Because you also mentioned to me before, and I touched on that you were interested in systemic interactions, and also autoimmune diseases as well that you brought up over message to me. Are there specific autoimmune diseases that you see commonly for people, whether it be stress injuries or others as well, that you're seeing that's quite common that you think might be linked to some of these injury occurrences going on?
Mm. Yeah, this is an interesting one, and that's almost like two layers of challenging questions. So I'll try and address them slightly separately. So
Take that, yeah.
in terms of the are there autoimmune conditions that overlay with stress injuries? I'm not sure that the inflammatory arthropathies do necessarily. Like I've not seen many cases of someone that's got rheumatoid arthritis or psoriatic arthritis developing stress injuries. Um, and again, whether something is like a diagnosed autoimmune condition, and this is probably to the other side of that question. Some of these things that are cluster findings you often see with autoimmunity, so like gut disorders, migraines, thyroid disorders, these sorts of things, they do seem to have an overlay. And again, there's data on this. So, I mean, the thyroid function is quite closely linked to bone metabolism and quite closely linked to stress injuries. But you also see a lot of thyroid dysfunction with people with autoimmune disorders. So I think that whole axis is involved. But to the other part of your question, what I think I see in clinic is, and again, much like bone stress injuries being a spectrum of injury, I see autoimmune disorders and inflammatory disorders as a spectrum. And at the pointy end, you've got these diagnosable disorders like Crohn's disorder or rheumatoid arthritis, things that have diagnostic criteria. And if you meet them, yep, this is your diagnosis, this is your label. But what I reckon I see a ton of in the clinic is a spectrum of these things where you've basically got at one end people who are fairly inert and at the other end people who are highly reactive. And as they move along that reactivity continuum, you've got people that are showing signs that it's like, oh, does this suggest an autoimmune disorder, or does this suggest inflammation, systemic inflammation? And I reckon we see that a heap as physios. But it's not at a threshold that a rheumatologist is going to diagnose that. And there's not enough on the bloods to be really convincing for the GP to be like, oh, we need to send you off for this, or we need to put you on this medication, or whatever it might be. But I'm seeing people with all these little cluster findings that suggest that their body is reactive. And again, the hard bit is going, well, what's it reactive to?
Mm.
Is this a genetic predisposition? Is it something that's environmental? Is it something in your diet, something in your lifestyle? Because it's something. But I don't think we have the tools to be able to diagnose it, like certainly not as physios. I think I'm getting better at identifying it. But the hard thing is, like we talked about, identification without a plan isn't that useful.
Mm.
So I'm often talking with people saying, hey, like your body is showing signs that it's pretty reactive at the moment. You know, I'd suspect that your body's in a bit more of an inflammatory place right now. And then we've got to try to dig through some of those other variables. But as a physio, I need help on that. I don't think the GPs have enough tools to be able to assist with this at times. Sometimes a rheumatologist can help with this, but the barriers to getting to actually see a rheumatologist are really high. Could be 4, 6, 8 months to get in to see one. And again, if you don't meet these criteria, like these box criteria, they often go, oh, well, it's not my wheelhouse then. Which again, it comes back to treating the whole person. It's the holism of what's happening in a person's system. And that's the thing that's really interesting me at the moment, because it's a puzzle that I haven't figured out, and I don't think anyone will in any hurry. But I'd like to think we're getting better at it. And at least if we can get people around us that's like, hey, I'm seeing this, can we get you to see this dietitian, or can we get you to see this practitioner who can maybe help unlock a bit more of the puzzle? Hopefully we're helping take away some of these variables that I think do interact with bone stress injury.
If you had infinite money, infinite power,
Brian Johnson.
yeah, actually, that'll probably do. And you could, in your head, devise what would be sort of the ideal physio but holistic health like strategy for a new client that are coming in, and you were to try and provide like a rough sketch of what that experience might look like. This is a terrible thing to put you on the spot with, I know, but if you were to try and sketch out that ultimate sort of flow of how a person goes through and comes out the other side better than ever, what would that sort of look like?
Oh, that's an excellent question. I've conceptualize this idea of like the reactive clinic, which is basically around this. It's for all these people that get into this middle ground of like, there's some stuff going on with my system, but I cannot figure out what it is, and standard medical care can't identify it either. And I think this is relating to your point. What's the flow of it? So rather than providing a nice diagram, I'm going to provide like a toddler style throw paint on the wall
Sweet.
notion of it. It probably starts with a whole bunch of screening kind of information coming in. So you come into the clinic, well, actually before you come into the clinic, you've sent through as much information on your health as you can, answered a bunch of questionnaires. They're going to have to cover physical health, psychological health, diet, gut health, lifestyle, all these sorts of things, exercise, what you do. It's got to be multidisciplinary. I think, again, I believe in staying in your lane, but being open to what every sort of team member can bring. And also, if you're trying to be the everyman, it's hard, right? Like you can't expect to be across all these systems. There's too much. So I would like to see people have a really good doctor who's involved there, who's running a whole bunch of highly comprehensive bloods, get as much sort of detailed workup as we can. And I'd like us to move to a place in Australia where we're doing bloods and workup for health, not just for pathology. And I know there's a few places around that will do that, but it's not the norm, and it's expensive because of that, right? Because it's not the norm. But do some really extensive work up there. Do some screening and a check-in with a psychologist. Do a full physical examination with a physiotherapist and see where you're at. Have a chat with a dietitian. Figure out what the food, and really drill down on what that looks like, and then have some sort of really wicked algorithm in the background that can take all these variables from these things, tie in the bloods to what's happening with someone's physical examination, be able to cross-link all that stuff. Hopefully that's where technology in the future is going to be able to help us. But it's such complex stuff. Like, we don't have the data to probably do it in an evidence-based way, right? But there are clinics around that are trying to do this sort of approach. So what I'm describing, I don't think is necessarily novel. I think there's clinics that are trying to do this. It's hard, it's expensive, so it's only available to the few at the moment, and it's still considered a bit fringe, which is a shame, because I think it's actually looking at the holism of a person, which is where we should be in health, right?
And I think it'll be interesting because, I know when people try and map out the cost of it, it's a high upfront cost. And then the idea is that technically, if you were to put everyone through that high upfront cost, that the other end of it would mean that there's far less cost as a result on like the healthcare system, the services required to deal with unhealthy people, because the preventative, which this would essentially be in part preventative type care, should therefore negate the actual expenses that stack up towards the end. But again, there is a lot of capital up front, so it seems like an expensive thing to do.
Yep.
That's at least how the math seems to suggest it would work. And whether or not the model starts to go that way, you would like to think so.
Yeah.
But the incentive structure maybe isn't quite there yet.
Yeah, and needing like a 30-year, put the rain cohort through this or something like that, get 30 years worth of data, and then you could turn around and go, look at what we did. But having a political system that runs on a 3-year cycle go around for that, good luck with that.
Yeah, and again, the cost of that longitudinal study of 30 years with, even if it was just like 100 people, the cost of that for the 100 people would have to rank into the many millions. That's another.
And the other big thing here is like the onus is still on the individual, right? So you can get the best suite of practitioners around someone, put together a really good analysis and a really good plan, but a person's still got to execute that at the end of the day. And there's reasons why they might or might not, but humans are variable and they often go into it with intent. But for someone to be like, all right, I'm going to be pretty strict with my eating and make sure that these foods that don't suit me, I'm putting them over the side, and make sure I'm meeting all my exercise targets, and I'm setting enough time aside for my mental health, and then you got to hope that like shit doesn't hit the fan in life, right? With your family and your work and with all this sort of stuff, which it will. So that's even if you do all this stuff as beautifully as you can, there's still other variables that might go and get in the way of it, and we've got to be compassionate towards people about that,
Is that something that you bring up with clients as well when they're going through the process of trying to recover, whether it be a stress injury or otherwise? Do you speak on how to manage the failures or the ups and downs of that journey?
Totally. And I often set them up for it. It's like, hey, like most rehab's not a linear process of improvement. And I also don't want people to be too hard on themselves if they don't get it right. So again, these guys they're not pro athletes, a lot of them. And if you're not paid to play, like, well, if you've got to, look after the kids on a certain day, or you get sick, or you get dragged into other responsibilities at work, like you have to roll with that, and you can't beat yourself up for it either. So then it's like, okay, something's better than nothing. If you did one good bit of exercise today, or you got your diet a bit better, or you drank more water, great. You got to celebrate those wins, not beat yourself up and go, oh, but I didn't do all 5 of the things I was supposed to do.
So it sounds like in, again, the ideal world, a lot of testing up front, a lot of bloods, things to try and get a better understanding of the body as a whole, and this sort of multidisciplinary approach. Is there anything in the physio world specifically that you think needs to move forward or needs an update, or areas where physio should really be looking to improve upon, from your just perspective, not necessarily what you think the profession as a whole might want? Is there anything that you see that needs to move forward from the physio side of things?
So I'm not a huge fan of like protocols or blanket approaches. So I think everything needs to be fairly individualized, which makes it tricky in terms of a systems approach, right? Where you know, perhaps you would say, oh, everyone coming to the clinic, regardless of their injury, does a certain kind of process or a screen first. I mean, that might be ideal world. And maybe you could even have, like a physio assistant run through an hour's worth of tests at the start. Like someone comes in, it's just this total screening, and then they hand that to the physio before the first consult. And so the physio's got, oh, we're looking at, this knee injury. There's a couple of weird things happening on the back there. And, maybe we could be better around looking at the whole person from the start. Because I think, classic physio practice is we're time stretched a little bit, and we tend to go, okay, what are we seeing you for today? And we'll focus on that area. But we don't always get the time we might like to actually step back and go, what about the overall system here? So I think we could get better at that. Maybe there's processes around how we could do that. There might be technology that could help us, like people take a video at home of them running through a dozen basic movements, and that gets video analyzed by some software, and it's like, hey, this person can bend their back, but they can't squat. Stuff like that. So there's these little flags to be like, oh, we'll follow that up when we see you.
Are you guys using AI for anything at the moment, or tools?
Using AI, I'm using AI for my clinical notes. So that's been...
Is that Heidi?
A rabbit hole. Patient notes is what I've been using.
Get patient note, okay.
I've spent a year with it with the intent to roll it out across my team, but I'm trying to get it dialed in just for me. So I've ironed out most of the kinks in it, and it's pretty good. It's getting there, but it's taken a lot of work. And it is definitely better than old school notes. Like it gets...
Try Heidi.
Cuts through it. Yeah?
Try
you like
Heidi.
it?
Try. Like, as in, I used previous. I used patient notes very briefly. Didn't like it. I used some other dictation ones. Didn't like it. And then I used one other AI one a year ago or so. Just trialing out different ones. Haven't liked any of them.
Yeah.
And then using Heidi.
Yeah.
No sponsorship here, but Heidi Health or whatever it is.
But if you're around, Heidi, we're over here.
Yeah.
Okay. Cool.
Yeah. That's been. I can't remember how patient notes work, but I remember that it struggled to differentiate between like fluff talk and non-fluff talk, and maybe it's much better than it was.
I haven't had too many dramas around that. It's been pretty good for that. For me, It's getting the formatting in the way I want it to be and getting the right amount of content. So it'll overweight certain sections and underweight other sections for me. So that's been a bit of a challenge.
Okay.
But it's improving.
Is patient notes where you're leaving it to record for the whole session?
Yep.
Yeah. Okay. So same. And then when you say it's underweighting, it's just failing to record certain things?
Yeah, like we might talk through the findings on an MRI, but it won't put anything in about that. But it'll have several overlapping sentences about a pain behaviour, about the patient's goal. And I'll be like, we don't need 3 sentences on that. But I do want the MRI information. And look, it's an algorithm, it's guessing, right? So you can't expect it to be perfect. But there's little details I'm working on.
Give Heidi a try. You get a 14-day trial.
Okay.
Give it a
you
go.
sure you're not sponsored?
I'm not sponsored. You know what, Heidi, though, if you're coming, this could be the place. No, I because as soon as I started using it, this was like one of the first AI tools, I guess, that I just thought, oh my God, this actually saves me so much time now. It really
Yep.
does. It makes me just not worry about the difference between, I do like hour-long consults pretty consistently, because I sort of like the trying not just get too caught up on, if you've only got 20 minutes or half an hour, that's still a bit of time, to be fair. In initials, I don't think it's enough
Yeah,
generally for
agree.
me
You
anyway.
need more.
And then sometimes for follow-ups, if you've found that there is like a multi sort of complex stuff going on that might be, you think, linked to the person's plantar fasciitis or the knee pain that they've had for 2 years or the back issue that they've just seems to just come and go constantly, then yeah, I just find that hour long, I can talk out with the person and the Heidi Notes collects everything, and then I can just add a little secondary summary at the bottom for myself. So I know,
Yeah.
great, everything that I need is captured that I can go back through in detail as needed. And then if I want to tack on just an extra line or two at the end,
Yep.
just to make sure that that's a quick reference point for me for when I reread the notes, in
Yeah.
case for whatever reason I've lost the ability to quickly go through like I usually like to. So yeah, for me, I was like, my money will be going out of my account for this.
Okay. Yep.
That's fine.
Good to know. I think for me, the other thing on it is mental bandwidth. So
Exactly.
you get to the end of the consult and you're not having to go through the whole thing. It's like it's all there and you're just doing some edits and some tweaks. So that's helpful. I want a good AI exercise rehab tool. So there's none on the market right now. I've been chatting with the mob at Seren Health, which is a fairly new crew. Because basically I just want to be able to say, hey, build me a program with 3 sets of 12 RDLs at this weight, 3 sets of 6, Bulgarian split squats, whatever. Talk it out and bang, it's just done. I don't have to search, drag, drop, all the rest of it. So we've got good exercise software, but it's not as good as it would be if you could just talk it out, or better yet, it just pulls it directly off your Heidi notes or your patient notes, and then just here's your program, built it. The outcome for the person is no different. They're getting the same program, but just for us as practitioners, if that unweights us from the admin, we can put more into a consult, and that's what it's about.
Yeah, the time saving for it, again, it just, as you say, it's that little bit less fatigue that you get from it. It's that little bit of extra time that you don't have to spend, and that really does free up a lot of bandwidth. And then on top of that, you've then got the added benefits where you'll get to improve your overall patient care as a result. And one of the things that I'm liking with the note side as well is I'm just trialing out. You have your own set of notes, and then you ask it to do a patient summary for you that you can send to them, so that they've got their own record. Because the number of people that will come through and understandably have had issues, and there's no great transactional history of someone's health when it comes to allied health, or not nearly as much. From the GP side, maybe there's a little bit more from there, but typically the person goes, this, like I had this thing and they did a bit of this to me. This was like a couple of years ago. I don't really remember.
Yep.
And there's no way for them, without calling up an old practice or doing like a big email sequence back and forth, to like find out what do they do and why. Which again, for continuity of care and understanding what's going on, I think would make a big impact. So if someone moves away, then go, oh yeah, I used to see a physio, and this is what we did in the past few sessions.
Yeah, for sure. And I think people can only take 3 points away from a physio session. You can spend that whole hour with them and do some great stuff, talk through some really good topics, but they're probably only going to bring 3 things home. And that's okay.
If you're lucky.
That's just the human brain.
Yeah.
Yeah, or they walk out and go, oh, apparently one leg's longer than the other. And you're like, shit, really? Of the whole consult, you latched onto that?
Yeah.
But I think they can only take those few things away. So summarizing that makes a lot of sense. And the other thing I think we've got to get better at, and I think we actually probably almost did this better in the past, and we're detraining it at university at the moment, is diagnosis. So I'm really big on accurate diagnosis. I just think it's critical, which sounds like, for the layperson listening, they'll be like, well, duh, of course you have to diagnose something. But there's been this big movement in physio away from specific diagnosis, and it's been driven by, what we're seeing in the research, saying, okay, well, most back pain we can't definitively diagnose as a structure in consult. And whilst I accept that that's the case, there's a lot of stuff we can diagnose, and we need to be hanging our hats on something, particularly in the periphery, in the limbs. So people walk away going, "Oh yeah, the physio's got a good read on what's going on. I've got a name for this. I've been given good information about it, and I have a plan, and I know what's happening." Whereas if you follow the modern diagnostic terms, and someone comes in, and you say, "Oh, hey, you've got non-specific back pain," then the person goes, "I know I've got back pain. I need you to tell me like what it is and what I do about it." Or it's like, "Oh, you've got you know subacromial pain or rotator cuff related shoulder pain." It's like, call it a rotator cuff tendinopathy, or call it a rotator cuff tendon strain. If you're wrong, you'll find out eventually on a scan. But if you give it a label and you treat it for something, you're treating a target. If you're diagnosing something as a rotator cuff tendinopathy, your management should be different to a subacromial bursitis. So you're better off labeling it, treating it as one of them. If the person gets better, chances are your diagnosis is correct. And if they don't get better, you've got to question your diagnosis. But at least give it a target and a label, give them good information, not shitty information about the condition, and then have a plan.
I think you're right in the sense that setting up expectation of whatever you believe the issue is, there should be a process that would come to follow if you're correct in that.
Yep.
Right. So if you're
It holds you to account.
Exactly, it holds you to account. I think I'm on the side of, I think diagnosis is helpful, but sometimes misleading. I think sometimes diagnoses
True.
are also, again, sort of like not exactly a cop out, but it's a best guess, which again, it's sort of like I think this, I'm going to just say this for now, trial a few things. Okay, that didn't work. All right, so, okay, maybe it's not that. Maybe it's this diagnosis, which to your point does mean you're essentially doing a kind of differential diagnosis, trying to knock something out of the way and say, well, that didn't work. So, okay, we must go down another pathway. So I get that side of things, but I do find that sometimes the complexity of why a certain thing, so something like a shoulder impingement, which can be a multitude of different structures and issues going on, and then how that structure, why it is that there might be an impingement, whether or why is the bursa inflamed. Just because the bursa is inflamed, does that mean it's the bursitis is the problem, or is there another problem that created the issue that's loading into that bursitis? And so sometimes that's the only issue I have with the diagnosis side, is if you get very, very specific about it, it sometimes draws you away from the, okay, well, what are the global driving factors of this? But what I do really like is going, look, this is what we believe is happening. This is the reason why we think it's happening. So if we address this, we should expect this.
Yeah.
And as long as you're being very clear about what you're expecting to occur, I think that exactly right. We want accountability for what you're doing.
I think that's a great point. And I think what I'd also say is the longer a pain problem's been around, or the more complex it appears to be, the further I step away from diagnosis. Because as we know in that stage, the structure becomes less critical, and it's more likely that you've got a sensitized system. But I think also, in most cases of acute problems, like there is going to be a structure. Like that, the most extreme example, you go and break your wrist. It's a bone injury. Yeah. It bleeds. It hurts. We know where the pain comes from. We don't say, "Oh, you've had an unspecified wrist injury." No, it's like, no, that's a specified wrist injury. So where we can be specific, I think we should be. And then where things are being complex, long-term, then the goalposts shift, and we've got to be a bit different in our language and how we communicate it to people.
Yep, I would agree with that. And the acute v sort of chronic, I think, is a really good sort of spectrum to help gauge your confidence for those types of diagnoses as well. As we're sort of starting to wrap up, so one of the main, again, injuries, I guess, that we've sort of touched on is some more of the stress injuries. Are there any things that maybe someone that listening might want to pay attention to help them understand that, okay, maybe I should be trying to address this pain that has been lingering on for quite some time, or some steps that someone might take in order to try and better assess whether or not they need help, or whether they might have something like a stress injury occurring?
Yeah. So there's probably a few maybe clinical pearls that I'd speak to on that. One would be don't believe the textbook. So people think, okay, a stress injury behaves like this. It's a gradual presentation of pain and gradually gets worse. It's like they're highly variable in how they present. Some of them come up really quickly. Some of them come up during the activity. Some of them come up afterwards. Some of them are next day. Some of them hurt during, some of them hurt afterwards. So you can't ascribe any too much meaning to any one point here. What you've got to be on the lookout for is, does this person have a training load related issue that could produce this? So you've got to really dig on training load. You've got to dig on biomechanics and go, okay, is there some sort of limb symmetry issue here, or sports related factor that could be driving this? And you've got to screen for all those extracurricular aspects we spoke about that could contribute. So you've got to do all of that really thorough screening and not just lean on, oh, well, they said it doesn't hurt while they run, so it's not a stress fracture. It's like, that's not necessarily true. The other would be, the majority of these are things that we can touch. Like most bones in the lower limb, you can palpate them. So every bony site essentially in the tibia, tib fib down, you can palpate them. So you've got to be really good on your surface anatomy and your palpation. If you poke straight on a bone and it does not hurt, that's helpful. And if you poke straight on a bone and it's got focal tenderness, again, that's helpful diagnostically. Gets a little bit harder as you go up the chain, femoral neck, femoral shaft, you can't palpate those directly. But where you can use bone palpation, it's a really helpful tool. And then the other thing is, related to not going too much off the clinical thing, don't be shy to get someone else involved. Typically I would recommend a sports physician because, again, they're quite good at seeing the holism of things, and they can organise the imaging and they'll give you that second opinion and they'll do the medical screening for the hormonal stuff, for the metabolic stuff, all those sorts of factors that come in too. So I guess those would be my thoughts.
Well, I wanted to, again, thank you for coming in to share a little bit of knowledge about sort of stress injuries, and hopefully giving a few people out there a bit of an indication or an insight as to some of the factors that might play a part, some of the things you might want to look at, and I guess part of the process that we're usually likely to go down in order to treat it. So thank you very much for coming through. I'm sure we'll speak again in the future about some other topic or issue, but it's been very good, Ben, so appreciate your time.
That's awesome. Pleasure, Harry. Thanks for having me along. Enjoyed it.
Sweet as.